Good afternoon. My name is Christina Papernik, and I'm a master's candidate at the Harvard School of Public Health in the Department of Health Policy and Management. As part of the Decision-Making Voices in the Field speaker series on women in leadership, I'm pleased to welcome Ms. Sujatha Rao. Ms. Sujatha Rao is an exemplary leader in public health. She did her post-graduation at Delhi University and later earned her master's degree in public administration at the Harvard Kennedy School. Ms. Rao is also a Takemi Fellow at the Harvard School of Public Health, and we are fortunate enough to have her joining us again as the inaugural Grow Harlem Brundtland Senior Leadership Fellow. Ms. Rao has served the Indian government in a number of different capacities, from serving as the Secretary of Family Welfare in the state of Andhra Pradesh, to working her way up as Director, Joint Secretary, and finally as the Union Secretary of the Ministry of Health and Family Welfare for the Government of India. While in her position as Union Secretary, Ms. Rao launched the country's first ever national program for non-communicable diseases, and also established critical regulations for the medical education, drug, and medical device fields. She also worked to help revitalize the country's primary healthcare system by introducing concepts such as performance-based financing. Among other achievements that should not be overlooked, Ms. Rao also worked as the Director General of the National AIDS Control Organization in India, where she increased the organization's capacity and ultimately helped bring down the new rate of HIV infections by 50%. Ms. Rao has served as the Vice Chair of the World Health Organization's Global Advisory Board on Nursing and Midwifery. She was the chairperson of the Portfolio Committee of the Global Fund for HIV/AIDS, TB, and Malaria, and is currently on the Global Advisory Panel of the Bill and Melinda Gates Foundation. Ms. Rao is also the founding board member of the Public Health Foundation of India and has represented her country on boards of the WHO, the Global Fund, and UNAID. With this impressive background, let's now hear how she does it. Please join me in welcoming Ms. Sujatha Rao and discussing her reflections on leading India's national health organizations. And now I'll turn the seminar over to Professor Peter Berman.
Thank you. Thank you very much. Welcome. So welcome, thank you, all of you, and Sujata, it's a great pleasure for me to share this event with you. We've known each other a long time, more than 20 years, and we've had the opportunity to work together in many different settings. I wanted to just start with a couple of reflections, setting a bit the context within which I think we want to discuss your leadership experience. India is a world power today. The second most populous country in the world, 1.2 billion people. As many have noted, the world's health accomplishments in many ways depend on India's health accomplishments. The efforts to achieve the Millennium Development Goals globally will not be successful unless India achieves the Millennium Development Goals. And India also has great ambitions for its future and concerns about the role of health and its health system in achieving those future ambitions. So I think your experience has been an incredible opportunity to lead and guide that process. I want to also note something about your own experience, which I think is quite unusual. Sujata has been an Indian Administrative Service officer for most of her career. Many of us might not fully understand that in the Indian Administrative Service, what that typically means is that you move from one sector to another throughout your career. You don't stay with any one subject. But somehow Sujata, and I think this is in part a reflection of her own leadership abilities as well as determination, has managed to spend most of her career working on the health sector and health systems at the state level and the national level. So she is, I think, very much by far the most qualified person that has ever served in these high-level positions in terms of experience in health and the health system in the government of India. And I think that makes her a unique guest for us to talk to today. So I'd like to just start off with a couple of questions and give our audience a chance to learn more about your experience. And the first thing I'd like to ask you about is that you've served as the State Secretary of Health, the senior-most government official at the state government in a large southern state in India, Andhra Pradesh. And you've also served as the first woman Secretary of Health in the Union Government Ministry of Health, looking out across the whole country of 1.2 billion people. Tell us a bit about the differences you experienced as a leader at the state level and the national level, and what kinds of demands and requirements these two different kinds of positions placed on you.
That's an interesting question, because I never really thought of comparing the two. But now that you mention it, the state level, I was Principal Secretary Health in two times in Andhra Pradesh. That's a state with 8 million population. And you know, the difference between that and being a union secretary is that at the state level, you're really close to issues and close to the people. There's no passing the buck. It just comes onto your table, and you have to own responsibility to whatever happens. So one is that you are directly accountable. The accountability level to the people is very, very high at the state level. And if you have a chief minister who's very supportive, as I did in both the stints, you can do much faster decision making than is possible in the union government. It's just between you two. You have the initiative, you write up the proposal, you can literally take the file to the chief minister, provided he trusts you and he likes the proposal, he just signs, and that's it. And you just come back and issue the orders. So the decision making and the ability to implement is much faster at the state level. But in the center, in the federal government, it's a lot of management, time management, people management. You're accountable to a large number of organizations. There's a central audit and accounts. There's a parliament oversight. There's a prime minister's office. There is the media, and there are the NGOs. There are the state organizations, your lateral working relationships with other ministries. So it's a lot of time goes in meetings and in discussions, in negotiating positions. So a lot of my time used to be spent on, you know, again, briefing your minister. Parliamentary work takes a lot of predominantly a lot of time, and the parliamentary oversight is quite high in India. And then there again, you know, the basic thing in the federal union secretary post is that you've got to be much smarter. You have to understand issues very quickly. There's no learning curve. There's no time given to you, and you dare not fail. So the system is very harsh, and so you have to be very quick, and you're doing about 10 different things at the same time. So you know, unless and until you are very strategic and you know what you want to get and you know the system, functioning of the system very well, then you really are in a strong position to negotiate your various getting your decisions very quickly. And a lot of time also goes by the cabinet. You have to prepare a lot of briefs, and particularly getting the budget approvals is a long process, negotiating with the Planning Commission, the Ministry of Finance, and then finally the proposal goes to the cabinet, and then you have finally the Supreme Court. You know, in India we have this public interest litigation, so anyone who doesn't like the fact that the government has not taken a position or has taken a position which they don't like, the people can go to the Supreme Court and file a petition. And then, you know, drawing your affidavits and filing your affidavits and seeing that also is very, very time intensive. So in the central government, you get very little time to really go to the field and undertake field visits and see how your programs are being implemented. Much of the time goes in these negotiations with different actors and stakeholders. So it's a far more demanding job than a state level job. It's much more information flow is there. Your capacity to synchronize all this information and constantly giving guidance and direction is far more demanding at the federal level. So it's an interesting comparison, but I never thought of it, but I think it was very, very hard work.
And maybe you could expand a little bit on one aspect you mentioned. You know, India, I think, is a very special environment in terms of the vibrancy of civil society, the vibrancy of the press, public debate, public discussion. Were there differences in the central and state level and how you had to manage that engagement with the public and with the press and, of course, the international community? And
with the state level, again, as I said, the accountability is so much sharper, and therefore media criticism is also a lot more, and you're far more accountable. At the federal level, I thought what was very interesting was that you have to negotiate a lot more with the state governments, because in the India's constitution, health is a state subject. So while the central government has a leveraging power in the sense, because we give a lot of funding support, financial support to the states, there is moral persuasion or putting conditions for the funds that you're giving and leveraging your own position to nudge the states to achieve your goals is oftentimes quite tricky. And it's though the central government does have the money power to be able to get the states to agree to your agenda, but very often it becomes very difficult because the states have their own pressures and their own pulls. So sometimes it's difficult. For example, medical education is something I spent quite a significant amount of time. That's in a very bad shape in India, and it really calls for a huge amount of reform to get quality education. Now, medical education falls under the concurrent list, which is both the state and the center have, but center has a huge jurisdiction, and the Medical Council of India is the regulator who is accountable to the central government in accordance with the Act. So you do have, so there I spent a lot of time in trying to get an entrance exam to we have MBBS, which is a 5.5-year course, which is undergraduate. It's something like your MD, and then they further specialization, they do another 3 years. So for this, I wanted one exam throughout the country to be able to get students some level of comparative competence among the students, and to see that if you have an entrance exam and you have some level of competence established before they enter the college, and then again the exit exam, because we have a lot of private colleges of varied quality, and again the exit exam to be done on a national level, you will be able to ensure some element of uniformity in quality, which is not really the case. There are a lot of private colleges which don't really have the full faculty. The way they teach and the outcomes are quite varied from what the standards would demand. But that was something that was impossible for me to negotiate with the state governments and get that cleared. So there are a lot of pressures, because a lot of the private colleges have a lot to do with the political nexus at the state level, and they don't want any national standardization, because they do admit students on the ability to pay, not on merit. So if you have a centralized exam of entrance and exit, then it would compel them to take people who have merit and may not have the money. And so it's a very complicated relationships that take place. But in terms of improving quality of medical education, with this division of powers and responsibilities between the center and state, you do have a lot of problems in trying to negotiate a common position.
Good. Well, thank you. So let me turn to a different subject, the subject of HIV/AIDS and the global epidemic. You served 3 years as Director General of the National AIDS Control Organization, which is a body associated with the Ministry of Health, but a separate entity that actually manages the country's AIDS control programs. I remember in the mid-2000s a lot of scare stories coming out around the world about how India, just by dint of its numbers and the rapidly increasing epidemic, was going to essentially roll off a cliff, that it was going to be severely affected by rapid increases in AIDS infections and cases. Today, I think the world sees India as having been fairly successful in controlling the advance of the epidemic, and the cliff seems to have receded. What can you tell us about your experience leading that program and how some of the hard issues you had to manage as the Director General?
Peter, I mean, for all the posts and the responsibilities I held, I think my stint at NACO was just about the most challenging and the most wonderful stint in my whole career. When I joined the National AIDS Control Organization in 2005 end, it was December 2005. First of all, I was very reluctant to get in because I was Principal Secretary in Andhra, and I had got several very, very important health reform issues cleared by the Chief Minister. I was on my way to really bring in several changes and a lot of reforms that were badly needed in the state. And it was at that time that I got this promotion and I had to shift to the federal government. And when I went in, that National AIDS Control Organization was a complete story in disarray. There were a whole lot of people not talking to each other, in fact fighting with each other. There were people who were looking after areas which they were not competent to do. There was no strategy, there was no direction, and it was a laissez-faire kind of a situation where each one could do whatever they wanted. And there were the donors who were behaving very, the prima donna kind of role, that they knew everything and they had to tell NACO what to do, and they would have their own person. So in fact, a time came where there was absolutely no alignment between who was doing what, and the government was completely on the defensive. Every time a guest would come to India, particularly in winter, they all arrive from the US. They never come in summer, so it's always November and December. And and they would come and say, oh, India is sitting on an atom bomb, its actual number of cases are 25 million, and they're still in denial. They're just saying it's only 5 million because the official figures showed about 5.1 million were the estimated number of infected people. And they would just keep coming and making some statement or the other. I remember once Richard Feasham came and said, circumcision is supposed to be so good and so an excellent form of prevention, and India is not taking it up. Now, India dare not take it up because of the so many religious associations given to this whole, so science is one thing, but translating it and putting it into a policy sometimes becomes another thing. So then there was a big uproar that what is, he's saying and so on. So India was very much on the defensive on this whole battle of HIV. And if you remember, in 2005, HIV was literally globally the sexiest topic to talk about. It had the highest amount of resources. It had a very high level of political attention from the US president downwards. So it was in that kind of an environment that I was brought in to set NACO right. And honestly, I didn't think that I would ever be able to get anything done. But the first thing that really I sat down and I said, now what do we do? And the first thing that comes to anyone's mind, I mean, the most important and critical issue if you want to make a difference is to have the instrument to make a difference with, and that's your organization. So long as NACO doesn't matter, as long as NACO is in such a disparate and issue without any direction, no one's going to pay attention to you. So the first thing that I had to do was to get rid of the people. And since I was in the ministry before, I knew most of them. So it was sometimes hard to say, sorry, but you may be good, but you're not up to the mark to the challenges that we face today. So send away some people, get some more who are competent. And then the government had only sanctioned 50 posts. That's 50 people who could work in NACO, and I needed something like 150 people. So the remaining 100, we did massive contracting. So in a year's time, we recruited another 100 to 150 people, and I sent my teams. We just didn't advertise and seek because everyone's CV looks very good. So it's you can't go by CVs. So I had sent my teams to the best schools in India on social work, and who have on rural management. We have some very good institutes. So they went there and did campus recruitment, and I got some of the finest students who topped those schools to come and work with me, and I paid them very well. So and that's how we built a critical mass of extremely bright and motivated students, people who came and worked on a contractual basis with NACO, and we quickly got the organization up and running within a year's time. Now, since I had got these very bright minds, and we spent a lot of time on their training, in fact, I even sent some of them to East West Center to understand how you do analysis, data analysis. That was considered to be one of the best institutes around. So while we were ramping up the entire quality assurance and all these methods, I had to be careful of the donors, because anyone who's praised by me, donors would offer him a job and take them away. So I had to keep the donors on leash. So I had to call them and said that any one of you poaching on even one of my people, you're out of business with India. You may leave the next day. The airports the doors are open. So you dare touch any one of them. They're petrified. And they really took me. They were so petrified that one of my officers did apply for a UNAIDS job, and the guy rang me up, can I see his application? I said, no, you can't, say it quickly. So, you know, because they get the field experience in NACO, which is what the donors want. And they want these people. So I then had a meeting with them, and I said, look, you guys, your success depends on my success. It's NACO's is the only one which can really scale up and achieve the goals of HIV response. And if I'm weak and I'm decapacitated by your taking away my people, and then you come to help me build my capacity, it's a no-sum game. We can't keep going in circles. So I said, don't do that. You please strengthen me by bringing me the best people around. And sometimes the best also need more money than I can afford as a government. So you please put your people here and work as one team. And I think they saw the sense in that because, you know, frankly, from their point of view, for the last 5 years, there was absolute zero leadership from NACO, and they were not really getting anywhere except holding workshops and seminars and workshops and seminars. So therefore, here they found that I was somebody trying to do business. And so therefore, you know, Gates Foundation, USAID, UNAIDS, they all pulled together, and they really did get extremely talented, very experienced senior people to work as a technical support unit, but within NACO. In fact, DFID used to have a technical support model where they would have a technical support unit, but so far away from NACO office that I had to, you know, I used to forget they were there, and they'd wait for my call to tell me how to support me. So I said, this doesn't work. You've got to be inside NACO. You have to take responsibility for the advice you're giving, and you better be a part of the whole team. Blame, shame, credit, or whatever it is, you're a part of the whole story. So that's how I opened my doors wide. Windows were open, and I allowed anyone to come in and work with me shoulder to shoulder. So that was getting the donor and then support. And then the most important thing thereafter was, what's the strategy? We don't have a strategy. How do we build one? So in this building of the next 5-year strategy in 2007 was it was very innovative because, you know, I'm a dyed-in-wool bureaucrat, and bureaucrats just work within their own four walls and with their own organizations. So this was something extremely new, and I really took to it very quickly, fortunately, was that, you know, the strategy was being built in the public open. I mean, there were people living with HIV/AIDS, there were civil society organizations and NGOs, there were donors, there were all these stakeholders, there were doctors, academicians. They could all comment on the strategy as it developed and evolved. And anyone could give me, if they had done any pilot project anywhere, they could give me their evidence, and we found that evidence worthwhile to work a strategy, intervention around it, we would use it. So it was a very, very participatory process. And it was, the previous 5 years, if $500 million was the budget, for the next 5 years, we took it up to $2.5 billion, and we got the money. So it was a 5-fold increase in the budget, which normally, as you know, budgets would increase only 10% incrementally year on year. At best, you can double it if you're very fortunate. But we had a 5-fold increase, and everyone said, how can you get that kind of money? And we did, because if you have a good strategy, you have a good organization which is willing to provide you the leadership, and you have alignment of all the stakeholders, then, you know, it is possible to make a good case to get the funding. And that's how NACO was built, very much based on evidence. We had a lot of surveillance sites that were really, that's called sentinel surveillance. We had about 700 of them. In a year's time, we increased it to 1,400. We doubled the number of sentinel sites. And the treatment was hardly 20 or 25,000 when I joined. And by the time I left, it reached more than 300,000, and I think it's now 500,000. Now, the important trick on what I found most satisfying was how I learned on the job, and the biggest challenge for me was how to scale it up. How do you scale up interventions throughout the country? So, and for that, we also felt that, you just opening centers and positioning people is not enough, because the quality of treatment that you get in Kerala, you should be able to get the same quality in Kashmir. So that brought us to the concept of standardizing every intervention. Every intervention was costed. Every intervention had an operational guideline. The operational guideline could be read by any one of you who don't know anything of the program, but you'd get insights into saying what are the aims and objectives of this particular intervention, who is the target group, what is the amount of money that is to be spent on a unit of that intervention, what are the kind of skills, competencies, capabilities that are required, what are the kind of personnel that you need, and what is your monitoring format, and who do you monitor at what frequency and when. So, it was these operational guidelines for every intervention. So, by the time I left, we had 18 operational guidelines for every intervention, and these then helped to standardize. And it was the structure that we had given to NACO. The teams, each intervention had, or one or two interventions had a team, and these teams, their responsibility was to go to the states, have these explain the standards and the guidelines, and also enforce them. So the second most important thing that went into scaling up the implementation was very, very intensive reviews. My level every Monday with my division chiefs, and then once in 2 months with the state aid society project directors, and then the teams from NACO would go in-depth reviews in different states. And every team that would go out to a state had to say what they were going to be looking out for, what are the problems that the state is facing, and what are the problems that they're going to address in their visit, and what are the problems they had visualized and have they been implemented, the decisions taken in the previous visit. So they were accountable for these visits, not that they just went and chatted up some people and came back. They were very purposeful, and I used to get all my feedback through the review notes that these teams would come back and give me. So I literally knew everything that was happening throughout the country. So that's the first hallmark, I think, of leadership. I think there are two things. One is being accessible. My telephone number was known to everyone. The last sex worker to my next in command would know my cell phone number. So anyone could ring me up anytime, and no matter how busy. That's a discipline I maintained even when I had a tougher job as a union secretary, that I would always respond back to SMS or to a phone I got, because you never know who's giving you what information and how important it is. So one is that access is something that I learned when I joined service in early years, and that's a habit that has really paid a lot of dividends to me. And the second is listening, therefore, to what the field tells you. And the third most important thing was getting these reviews done. And when you go to the field, it's just not a question of what have you done with the money we have given. It's not that kind of auditing. You're really training them, you're patting them when they've done good work, you're nurturing them, and you're building in leaderships at the local levels, because at the local level, and people do good work, they want to show it. They want somebody to come and acknowledge it. So it is this kind of eye contact, as I used to tell my officers, that we should know the people who are implementing projects in the field, and they should be feeling a part of the whole exercise that we are doing, and they must understand why they're doing what they're doing. But in conclusion, I would just like to say my most challenging part of this whole job was reaching out to the marginalized populations. HIV, as you know, it's 85% of HIV transmission is through heterosexual route, and it was really the men having sex with men and commercial sex workers and injectable drug users who were the, I hate to call the word transmitters because that's not polite, who transmits the infection to whom I don't know, but they were a very core group through whom the HIV infection was getting spread out into society. And working with them, going and sitting with these sex workers, sitting and talking to these MSMs was something that was an extremely, gave me a lot of insights on the underbelly of our societies. You don't really see it. You think you've seen poverty, but you don't see the kind of vulnerability and the kind of acute vulnerability and poverty that you see among sex workers who literally have to sell their bodies for what, to save their child. They don't have medicines, they don't have money. I mean, it is something, the humiliation that they go through in their own lives is something, those were insights which I could never have got in my own life. So they opened up a whole world of reality that is there everywhere. It's in this country, it's in China, it's in every place. It's a matter of how sensitive you are to your surroundings. And oftentimes we are not. We don't know what's really happening, why somebody is taking to a drug, how is he becoming a drug addict. We are so easy to condemn. We are so easy to find fault with. But what are their own personal vulnerabilities is something that, this job really taught me a lot. And I came out very, very humbled by every time I would interact with these groups. I would come back and say, how we whine, but look at these people with nothing at all, and they still are chasing to want a place to live in society with dignity. And so we did remarkable amount of work in empowering sex workers so if you come ever to India and say a place like Mysore or Kolkata, any place, today I have the satisfaction that one of the workers who was just hooking around soliciting 3 years ago under a tree to any customer who would come, sickly, HIV, she's learnt English, she manages the cooperative that we formed, and she went to South Korea last year and gave a presentation in English to an international audience. Oh, they all stood and gave her a big ovation. So the potential that people have and the ability to bring out that potential and let them give their best, it is a very wonderful experience when you see people who are nothing, and then they, by just a little bit of nurturing and a little bit of support, how much of capacity there is, and how easily society just condemns them as bad people. Who are we to say they're bad or good? Think about it. And these were some of the experiences that NACO, and I was happy that McKinsey came and reviewed and gave us an extremely good report, assessment of NACO. And I think our strategy, India was the only country which had a homegrown strategy. The whole world was promoting treatment. We said no, not treatment alone, but prevention. 3/4 of my budget was for prevention. 25% of my budget was through NGOs working with these marginalized groups, and 25% on treatment. And we did well, and we reversed our new infections incidence of disease by 50%. So I think we have a lot to be proud of, and it was hard. It was a lot of hard work, but I think ultimately it was some very satisfying job. And the most important thing that I have always felt in my entire career, this again right from day one, was that if I'm really a good leader, then after I leave, what I have done should continue to work. I always assess myself as a bad situation, and a leader is bad that he goes and everything collapses. So I have this immense satisfaction that even after I left NACO and I went to the Union Secretary post, things have continued. And once you put in systems, and once you put in organizational structures, and you put in those instruments of governance, then whether the people on the top are good or not, as passionate or not, they can only make a 10% take it forward or take it backward. And this used to be an issue that used to keep coming from the donors. What after you leave, what will happen? We're trusting you, you're there, but you can be transferred out. So I said, no, then don't give it to me. You put in systems, you help me to put systems that whether I'm there or not, whether somebody else comes in or not, the systems must function. So this was something that we all worked in, and it was a great collaborative, the USAID representative used to come with me and sit on reviews that I used to hold of state governments. So there was never any barriers to say I'm government, you're a donor, and so there was this wonderful participatory collaborative environment. And I'm emphasizing it because it's not so in the Ministry of Health. And when I went there as Secretary of Health, I found all doors tightly closed like this. Not a shade of light can get in. And therefore, I think they're big losers. But that's another story.
Well, thanks. That's a very compelling story, both of leadership and the human dimension of these problems we deal with. So we want to take a few questions from the audience, and let me open it up for anyone to pose a question, if there are any.
Hi, my name is Jeff Urim, and I'm in the Healthcare Policy and Management track doing an MPH. And before I came here, I worked for Intel, and I did a little bit of work with some people who are over in India. And I also try to read the news a little bit and keep up on what's happening. And I was just wondering, I'm sure as you did your work, you probably ran into some issues around corruption. I mean, it's always something everyone has to deal with, and I've worked with teams from all over the world, and it's always something you have to deal with. And I was just wondering if you could give us a little bit on your strategy for dealing with corruption and what you did.
That's a very tough question to answer because corruption is just all over. And I don't want to mean to say that only in India, everywhere there is this corruption, but in India it's gone to a level which I don't think it can get worse. It really is bad. Now, what are the causes, what are the issues, one can't get in. But in the health sector, once I had a chief minister in Andhra Pradesh who did a survey to see which is the most corrupt department. And then the results were published and health was second or third. So, you know, it's all a question of, I think police and revenue, these were the two other departments. Now, I don't remember whether health came second or third, but I think we must have come third. But those two are terrible. So it was, you know, the whole issue is supply demand. And but in health, I see an element of greed that's also got in. I mean, there has to be some level of satisfaction to the earnings that you get, you know. You just kind of go on and on at the risk of even being unethical. That is where it hurts. And the corruption in the health sector is just not only government. There's nothing much because we already have a little budget. How much can you steal from that little bit? But it is in the private sector too. That is what is causing us a lot of problems because today we have a private sector which treats 80% of outpatient and 60% of inpatient. And therefore, you know, if for any scaling up for that great aspirational goal of universal health coverage, there is no way except to partner with the private sector, for example. India, the government doesn't have its own strength to be able to provide a universal health coverage for its people. So partnering with the private is very good, very important. Now it is here that, you know, corrupt practices have seeped in there too. There's a huge culture of commissions and kickbacks. So a doctor will refer, will have an understanding with a diagnostic clinic, and the patient will be sent there and he will get a kickback. So, you know, you don't know which drug you're taking because drugs, again, the pharmacy, the agent who goes marketing, he'll give you a higher amount if you prescribe the branded drug as against another drug. So you're getting, so in every aspect of healthcare services, there is this whole kickback culture, which is a very, very unfortunate thing that's happened because overdiagnosis, over-medication, you know, inappropriate medications, inappropriate surgeries that are being done. So this is, and it's not, both are into it, both public and the private sector. A government doctor in India, and because we pay them civil service salaries, and the market rates for doctors is much higher. So to compensate for the loss, they're allowed something called, they're given a small amount of money, but they're also allowed to do private sector practice. So this dual practice is another thing which is very, very corrupting because a patient goes to his hospital, he says, why didn't you come in the evening to my clinic and I will give you much better care. So there is this conflict of interest constantly. So government hospitals are have no patients, and the doctors, the private clinics are buzzing with patients, is the same doctor. So, you know, unless and until, like I was telling a very prominent private practitioner, that we can never be able to work together unless there is some level of integrity somewhere. Therefore, corruption is really a big, serious issue. And I don't know how, I mean, it's now the highest priority even in the political system because it's kind of pervaded everywhere. So but I think, and I'm very hopeful that, you know, there is a much more greater public awareness, and the only way you can curb corruption is having far more public information out there, telling the people what they're entitled to, and giving far more empowerment to the people to be able to come and ask and say, why are you doing this procedure when it's not necessary? You know, these kind of making people and patients more literate than they are. It's very difficult because health is the only place where the asymmetry of information runs. And even I, with all my understanding of health, if a doctor tells me to go through a surgery or go through a mammogram or go through a MRI, the likelihood of obeying him is far more than questioning him and saying, I think you're trying to just get me to take unnecessary tests. So this issue is exploited fully, and but I think we need to have more standards, standardized issues, get more protocols in, much more public information, and much more accountability systems to bring in greater accountability and oversight. So I think that's the only way I can see that corruption getting curbed.
And I think that India, this will actually be an area where India will have a lot of lessons to teach the rest of the world, given the openness of the society, the press, things like the Right to Information Act and so on, which I think are promising. So let's give another questioner an opportunity.
Thank you. I'm Shalupuri, and I'm going to be joining in the MPH Global Health this fall. My first independent project as a public health professional was when you were the Joint Secretary, and I'm so privileged because I learned a lot right at the beginning of my career. Two questions, actually. One is a more personal. As a woman, being in the Ministry of Health, what were the specific challenges that you had to face, and how did you overcome those? And my second question is more around India. What do you see as the most important public health challenge, not just in terms of the disease area, but other blocks in the health system? If you could comment on that, please. Thank you.
This question is often asked, how do you feel as a woman? Here I'd just like to qualify that the Indian civil service is being an elite service is very protected, and therefore whether you're a man or a woman, you're sitting in the chair, the authority is accepted. So you don't face the kind of gender discrimination that others, say the doctors or other scientists or teachers or women, other functionaries face in their in different jobs. So that is one aspect. But having said that, the discrimination is still there, and the gender discrimination is very subtle. It's extremely subtle and gets subtler when they're very nice and patronizing when you are not a competition. But when you get up and there are just that many posts, and that is the competition, as you go higher, the discrimination gets subtler and subtler. I mean, India has not been able to have a cabinet secretary who is a woman, even though we have had 2 cases where they were qualified to be cabinet secretaries. So on something or the other, they'll give an equivalent post, or they'll do whatever. We've had women diplomatic service officers go to the court challenging why one of them was denied to be the foreign secretary, and they allege that just because they're women. So there is this subtle discrimination that happens, and in very many ways, and right through my career, and you just sense that. And I think women have to work doubly hard to get that same level of recognition, respect as compared to the male colleagues. I mean, my male colleagues did damn all, and they didn't do very much, but at the same time, they'd be seen, all they would do is to attend and talk a lot, and they would be known as what dynamic officers, and here the women are plodding and struggling, and then they say, yeah, she's a good officer. This kind of discrimination does take place, and women have to work far harder to establish their own niche and their own credibility, which is unfair, but it's there.
So
and
your
the
second question
is, well, India, it has some plus points and some minus points. The biggest challenge is human resources. We just don't have the disease burden is galloping, both infectious, non-communicable diseases. Demand is increasing for healthcare. The money is somewhat over there. I'm not saying fully, but yes, India is in a better position to provide better budgets for health than it has in the last 60 years, but we don't have people. We just don't have the human resources, whether they're specialists, doctors, nurses, technicians, support staff, or whatever. So that is the biggest challenge, and it has been recognized for the last couple of years, but we've still not got our act. The issue is so hugely problematic. We have the money to set up medical colleges, but we don't have faculty. We have money to set up nursing schools, we don't have faculty. So this is our biggest challenge, and we've got to see, on 2 planes I think India will have to work on. One is taking advantage of technology. We can't have a teacher sitting there teaching one-to-one anymore, which was the strength of India's medical education in the past. We had excellent skill training, and our doctors, they made a big name even in the West, is largely because of the high quality training. So that will have to go. And second is to do much more simplification. Do we need a graduate nurse in a surgery room just to give instruments to the doctor? I mean, that can also probably be done by probably a lesser qualified. So we'll have to look at the job requirements and the qualifications that are normally put as way of standards, and see how we can try and use maybe lesser qualified but more skilled on the job kind of people than having to think that in a pediatric ICU you need a neonatologist. That's never going to happen, and we are never going to get that kind of neonatologist there. And so do you mean to say that we cannot have those ICUs when you have a huge disease burden, I mean huge burden of 30% of the 27 million giving birth being less than 2 kgs. So we have to come to much more informal and much more skilled training personnel. So HR is really a very major issue.
So we're running about out of time, and we have time for one more quick question and one more quick brief answer.
Hi, thank you so much for your talk. My name is Agnes Terry. I'm in the Health Policy and Management Department. I'm just wondering, for the students in the room, what suggestions do you have for us in our next year coming up of skills that we can sort of put in our toolbox to make these decisions and to tackle these challenges that we face?
The suggestions I have is that, I think if you want to be a public health expert, there are two things. One is you must really have some core competencies. So things like, what is any public health system, and particularly if you want to work in developing countries, would be epidemiology and biostatistics. I mean, that disease tracking and disease understanding, the preventive, promotional aspects rather than just the clinical curative would be, I think, of immense value. And accompanying that, I wish you could have that combination of also health economics, understanding where to maximize and optimize the scarce resources that you have, particularly in terms of money, and what is the cheapest way of getting the maximum out of that. Now the whole challenge in India would be to keep, say for example in India, would be to keep costs low, and we have to constantly be working for process and procedures which can ensure certain level of quality but at the lowest cost. I mean, I don't agree why US has to spend $8,500 per capita. I just, it's absolutely unnecessary when other countries are providing similar level of care at $3,000. Now, this is big debate because in India we are spending hardly $24. So we are at the other end of the spectrum. So, but at the same time, I think that's one thing that developing countries, and particularly countries like India, can give to the West, is how to keep costs low. And this is one discipline which I learned when I was here as a Tech MA fellow, is health economics, and if it could be matched with some of your core skills, that would be very, very beneficial for working, particularly to make a difference in the developing countries.
Great, thank you. So, well, I think our time is up, and Sujata, I want to express my appreciation. I'm particularly delighted that you did work doubly hard and that we have you here with us. I noted from Sujata's biography that she came to Harvard in 1990-91, and then again in 2001, and now again it's 2011. So it seems like we get the privilege of engaging with you every decade, and I look forward to the 2021-2022 visit, which we'll start planning immediately. So thank you very much.